All right, well, let's get started here. Welcome. This is the CCBCH Data and Reporting TA. Today is June 23rd, 2026. My name is Katie. I'm a research and data analyst with the state of Oregon. And today, who is also on my team is Gina Turini, who is also a research and data analyst for state of Oregon. Thank you everybody for being here today. Really appreciate it. And let's get started. All right, so just for some virtual meeting housekeeping, if you don't mind just raising your hand within the Teams features or submit your questions in the chat, that would be amazing. And then if you are speaking, just go ahead and identify yourself in your program, business, clinic. And then also just know that this meeting is being recorded and is subject to public record. I should also know I can't see anybody. I can't, so I don't know if you're raising your hand or if you're putting anything in the chat. So Gina or Chrissy, if you don't mind just interrupting me or just letting me know, and I can pause or we can navigate that when that happens. And for the agenda today, we have some high-level metric spotting that we'll be going over, as well as some presentations. The metrics that we're going over today are follow-up after emergency department visit for substance use, initiation and engagement of alcohol and other drug dependencies treatment, as well as preventative care and screening, unhealthy alcohol use screening, and brief counseling. We also are doing some Q&A and peer learning discussion and wrap up and resources that are at the end of the presentation. The presentations I had mentioned earlier are going to be done through other clinics that we are very thankful for that decided to volunteer to have these presentations and be here today. And they will be presenting on the FUA metric as well as IET. And I think I heard somebody talking. Does anybody have any questions? If
No,
not,
I think we
keep
just
going.
need everybody to mute themselves if they're not speaking, please. Yeah.
Got it. Okay, perfect. Okay. So like I said, we're going to be going over some high-level metric spotting. I do have a couple of notes though before we continue. So all of the metrics that we will be discussing today are calculated by the state, with the exception of ASC, which is calculated by the clinics. And then also note that all metrics today, when it comes to relevant numerator, denominator codes, as well as any sort of definitions and guidances, can be found in the 2024 SAMHSA text specs and resource manual. That link is provided at the end of the presentation today under resources. And then also, because we're going to be discussing a lot of substance abuse as well as alcohol, NCQA's medication list directory for alcohol use disorder treatment and opioid use disorder treatment medications is free of charge. And the link is also at the end of this presentation in the resources. And also additional notes, just make sure to be using the version that's current for the year that's being reported. All right. So the first one we're going to be discussing is FUA, and just be aware that there is an adult as well as child. And so we're just going to go over these very briefly before handing it off to the different, before we hand it off to CCMH for their own presentation. All right, like I had mentioned earlier, this measure is calculated by the state. This performance measure looks at the percentage of emergency department visits for clients between the ages of 13 to 17 years for child, or ages 18 and older for adult with a principal diagnosis of substance use disorder or any diagnosis of drug overdose for which there was a follow-up within 7 or 30 days. The measurement period for this is a full calendar year. So for example, you're looking at January 1, 2025 to December 31st, 2025. And then also for the numerator and denominator, there's two rates that are reported for the numerator. So the first one is the number of ED visits for which the client received follow-up within 7 days of the ED visit, so a total of 8 days. And then the number of ED visits for which the client received follow-up within 30 days of the ED visit, which 31 total days. And then for the denominator is all eligible ED visits. In regards to this, just again, as more notes, many examples of what a follow-up could be including visits with the mental health provider, opioid treatments, peer support services with diagnosis code of SUD, et cetera, et cetera. All the relevant numerator and denominator codes are all within the textbook manual, so you'd be able to look that up if you'd like. And then when it comes to the denominator, only one eligible ED visit per client is included within the 31 days. And then also if the ED visit results in inpatient stay, it is excluded from this metric. Right, and then we have the measure stratification. So just note that this stratification is the same across all the measures that we're going to be discussing today. So this is the only time we're going to be talking about it. So just know. But for the payers, we have Medicaid only, and then non-Medicaid, that includes Medicaid and Medicare dual. We have ethnicity for non-Hispanic or Latino, Hispanic or Latino, and unknown, and then race for white or Caucasian, Black or African American, American Indian or Alaska Native, Asian, Native Hawaiian, or other Pacific Islander, more than one race or unknown. All right, and it is now that time to have CCMH present on FUA. I believe, Jen, are you going to be the one who's presenting?
I am.
Awesome. Okay. So because I can't see you, if you don't mind just letting me know when you'd like me to switch over to the next slide, that would be great, and I can maneuver through it.
Okay, cool.
Okay. All right, here you go. I will mute myself.
Hi, everyone. Thanks for having me. I'm Jen Riefel. I'm a PMHNP and medical director at Columbia Community Mental Health. I started this role in 2014 when we became a CCBHC in the original pilot. My focus has been mainly on primary care integration and CCBHC implementation and overseeing clinical standards. So today, I'll walk through our workflow for follow-up for ED visits, for SUD, share what's helped us improve, and kind of be honest about where we're still pretty clunky. It's not a polished model. It's a work in progress that we built in real time. So I'll focus on what we're actually doing instead of, what's on paper. Next slide. Okay. So first I'll talk about how we identify and respond to the visits, then what actually moved our performance, and then kind of where we're still struggling. A theme you'll hear throughout this is that it's been a lot less about the tools and more about having a simple process that people can reliably follow every day. So prepare to be wowed by like our tech savviness. Okay, next slide. Let's see. Actually, we can skip this because you went over the metric. Thanks. Everybody knows the metric. Okay, so these are the areas that we focused on to improve: identifying the ED visits and admissions quickly, having clear ownership, and communicating clearly and immediately, engaging before discharge when possible, and reducing missed follow-ups. If I simplify that, it's really just speed, clarity, and follow-through. Because that 7 days starts to go really fast. Next slide. Okay, I'll walk you kind of through what a day looks like. Step 1, we monitor the alerts. We review them through Point Click Care daily. On Mondays, they kind of go back 72 hours to catch the whole weekend. Step 2 is to identify the ED visits and admissions from there, we sort through the alerts and flag the ones that actually are relevant. That filtering step takes time because we get a lot of alerts that aren't actually actionable. Step 3 is to do a manual chart review. Each alert is checked in Epic. Is the patient still active? Who's on their care team? This is not automated and is really important. OCHAN Epic goes back a long time. So, and we don't really have a choice on how those things are set up across the collaborative. So they filter out the inactive clients, and then the active clients are separated into those that meet the metric and those that don't. Step 4 is to notify the team. Previous to like 2 weeks ago, we had this daily email that went out that said all of the physical health hospitalizations, or to the specific teams, the physical health, the SUD, mental health, and I think actually people who are on the jail roster. But now it's an Epic through InBasket, which is a new workflow for us. And when we notify that for those that do meet the metric, we're really explicit in saying this meets the 7-day follow-up metric. You need to get this person seen within 7 days, or it says this is a physical health admission, FYI, no follow-up needed. Step 5 is to schedule it. The expectation is that the clinician gets the visit scheduled within that window. In practice, there's some variability here. Step 6 is if they're admitted or if they're still in the ER, we try to coordinate as much as possible directly with social work or discharge planners, and we try to schedule before they get out. We also try to talk to the clients directly before discharge. Confirming with them has actually been like the biggest predictor of success. I think a lot of times people leave and they aren't really clear on what the instructions are. They don't talk to somebody, you don't know what's been passed along. So talking with the clients directly has been really helpful. So super manual process, and but it is consistent and it's repeatable. Next slide. Okay, so some of the things that have made the biggest difference is ownership. We had a dedicated transitions of care manager that's now our intensive populations department manager. This kind of changed everything. I think instead of having it be everyone's responsibility, it's one person's responsibility and it has a home. Clear communication. We moved from like vague heads up, here's everyone that's in the hospital, to, hey, this person met the metric and here's what you need to do. Hospital coordination, when we can connect directly, like I said, and then that pre-discharge outreach has also been a big one. Let's see, one nuance. Oh, I already said that. Never mind. We can go to slide 7. Okay. Here's some lessons that we've learned or still learning. We have improved, but there's still some gaps. We don't have a true closed looped system yet. Once the message goes out, tracking what actually happens after that is a lot harder. And we're still, I think we just hit our 1-year mark with OCHAN Epic, so we haven't built all the reports yet. So trying to read the comments too. I'll get to questions at the end. Our alert system also brings in too many patients. I think it goes back 18 months. And so they may or may not be active. We spend a ton of time filtering out which ones matter. And then there's variations across teams. We do the same process for our mental health and for our SUD, and our SUD metric is better. Does that mean that team is better at following up? I do not know. And like I said, it's just a still very manual process. So I would say the workflow works, but it's not like the most resilient. And I think that, another thing that I didn't mention with regard to like system barriers is that we moved with Epic, we moved to centralized scheduling. So in our legacy system, clinicians were able to schedule the appointments themselves. Now there's the added step of having to go through the business center to like forward that InBasket message to also request an urgent appointment. Next slide. Here's some of our improvements in progress. What we're focusing on, moving to those Epic workflows. We're shifting from email to Epic in-basket and work queues, so this becomes trackable, assignable, and less likely to get lost. Standardization, we're building smart phrases, quick actions, automated steps, clear communication templates, and then also better flagging and encounter types. We've have a specific hospital follow-up encounter type that makes it a lot easier to track. And we want to do smarter tracking around no-shows, missed follow-ups, and completion rates. The overall goal is to move from person-dependent to system-supported. Okay, next slide. Oh, and in closing then, I just had a couple more points. Yeah, it's really just been about the reliable process, the clear ownership, and then being super explicit about what needs to happen. And we're still refining and learning, but we're happy that we did well on the metric. I also have Janelle, who is our transitions of care person that owns that, here with me today. I think she's on. So if there are questions, I don't know if there's time. I tried to cruise through.
No, yeah, we definitely have time for questions. We built that in, so that was lovely. Yeah, so we have a couple in the chat, and I don't know if they were completely answered. So maybe I'll start with Amber. Do you want to follow up on your question or further ask anything about that? If you'd like to, you're more than welcome to come off mute and ask that.
Oh, it's about who manually checks the chart.
Yes, I believe that's and then I don't know if you have anything additional you'd like to say about that in answer to her question, which was who manually reviews the chart and notifies the care team.
Yeah, and so we have Janelle Harrison as our person. I always forget her title. Used to be the transitions of care manager, but it's kind of it's a good thing, and it's also a bummer because when she is out, and I think that compliance has to get the notification first and then release it to Janelle, and then Janelle from there filters everything and sends out those automated. We have a smart phrase now that has the, hey, this person meets the metric, this person doesn't meet the metric, FYI things. So she's our person.
Perfect. And then we had a question from Katie who asked how you were getting that alert in your Epic in-basket. I don't know if you want to say anything more about that. And Katie, if you want to elaborate on that, you are also welcome to jump in here as well.
Sure.
Yeah.
Katie Binford, I'm from Lane County Behavioral Health. We're just starting our journey with CCBHC. And we are fairly new to Epic also, so we're learning all of the things. But I was curious how you were getting those alerts for discharges or emergency room stuff in your in-basket. Right now we have like a point-click care Tableau report, but it's not connected with Epic.
And I think you can get that done. And I think through Bamboo, they have like a thing that you can get money to pay for it too. So you wouldn't even have to pay the extra bit for the integration, at least for Ochin. On the Ochin side, we did. It's integrated in and it comes in through our outside messages. But I believe it goes through a layer either at medical records or compliance where they have to do the work queue and release it to Janelle. And then Janelle forwards it to the care teams in basket.
Thank you. I have
But
one other
before,
question
it wasn't
if I have,
integrated. Oh yeah, go ahead.
if that's okay.
Yeah.
Because you use Ochin Epic, and I'm curious just in general, with a CCBHC, are we allowed to be part of other programs also, like the TCM, Transitional Care Management Program, or CCM, the Chronic Care Management Program? Does anybody know the answer to that?
I don't.
Okay.
Will you put that in the chat and we can I don't actually know offhand, maybe somebody else on the call does, but if nobody on the call
You should be
does.
allowed
Yeah,
to
thank you.
do multiple programs when you are working through that. myself and the behavioral health division team and our team can support you in delineating those things. I think lots of states do those things within their CCBHC, but the short answer is yes, you can do those things and be a CCBHC.
Great, thank you.
Thank you so much, Katie. All right, then we had a question from Erin in the chat. I don't know if you want to come off mute and ask it, otherwise I can summarize.
Yeah, it just sounds like a lot of the solutions that you came up with were made possible when she switched to Ocean Epic. And I'm just wondering how many of these would have not been possible, the solutions that you described would not have been possible if you had not made that switch?
I think, well, we haven't built the automations and with the smart phrase before, so we didn't have that. And so previously, and it wasn't integrated. So previously people had to have specific logins for Point Click Care, what Collective Medical, whatever it was before that, pre-managed. How many names has there been? So they would log in, do that, and then do it through email. It was easier in a sense because we're not used to the new workflows, and Janelle had a rhythm of like what she put into her email template, and then the clinician themselves right there could schedule right on their schedule. It was a lot faster, I think, before because we haven't gotten into our groove. It just sucks because it's external to the system and you want it all in the system. And it'd be very nice that this happens automated, comes in, quick button to like meets the metric, to quick button to schedule, like to have it all automated, which is the goal eventually. So none of that was possible in our old system.
But it sounds like Point Click Care has been an important part of your process. Okay.
Mm-hmm. And we used to, when we had different reporting, we tried to get, even if it's state reported, try to track those internally the best that we could and push those reports out to management to see how we think we're doing with that 7 and 30 days. But we haven't had those built or able to push those out in quite a long time.
All right, we had Sierra in the chat asked how many on this call are using Ocean Epic. I'm not sure how to get that info, but as an initial step, if people are able to and want to give a thumbs up to her comment if they use Ocean, that might give us a little bit of a sense. Otherwise, I might have to think about how to gather that information. Other than that, though, I think that's everything we have in the chat. Does anybody else have questions they would like to ask of our oh, here we Amber, I don't know if you can come off mute. Oh, Amber says she's they're on Ocean. Okay, perfect. Jerry says the same. Okay, great. So there's some people responding in the chat, so that's very good. Yeah, so no problem, Amber. Does anybody have any other questions they'd like to raise their hand or drop in the chat? Either way, before we move along.
So I'll actually, and now I see Janelle. Janelle, you want to just come off mute and say hi?
Oh, perfect.
I wasn't sure if you could see me like shaking my head yes and waving, but yes, hi.
Yeah, thank you guys so much for putting together this presentation and answering all these questions. I think it's really valuable for everybody, so we really appreciate it.
Sure. Thanks, guys.
Thanks.
And if anybody thinks of any other questions, feel free. We'll do questions sort of after each metric and then sort of open up to general questions at the end. So if anything pops later, there will be more chances later in the meeting to ask questions. Perfect. Thank you so much. All right, should we head along, Katie?
Yep, sounds good. If you just don't mind letting me know next slide, and I'll
Oh
move
yeah,
along.
sorry. Yeah, of course. Next slide, please. All right, so I'm going to talk a little bit about the next metric before passing it off to our second presenter, which is initiation and engagement of substance use disorder treatment. So we can go to the next slide, please. You went 2 slides, I think. Oh no, you're good. Thank you. Perfect. So this metric is the percentage of clients, adult clients, age 18 and older, with a new episode of alcohol or other drug dependence who received either initiation is one metric, and then the second is engagement of SUD treatment. So we're looking at for the first, we're looking at the percentage of new SUD episodes that result in treatment initiation. And like all these other metrics, as Katie mentioned, the specifics of kind of the details of what is required are in the technical specifications at the end, but this is what counts as initiation of treatment within 14 days. And then for engagement, they have to have evidence of treatment engagement within 34 days of initiation. So for this metric, the measurement year is again the calendar year, so January 1st, 2025 to December 31st, 2025 for example. So we can go to the next slide, please. Yeah, so I think we have kind of covered this already, but just, to be sort of specific again about clients 18 and older, this is initiation is one metric. So initiation is within 14 days of the initial SUD episode. And we're only including clients in the eligible population who are continuously enrolled and also have that new SUD episode within the period. Next slide, please. And then very similarly, we have engagement. And so these are clients who had that initiation and then additionally need to have 2 or more SUD services within 34 days of that initiation visit to be considered to be engaged in care after their initial SUD episode. I think that is kind of the high level overview. So I think we can go to the next slide, which I think is to pass it off to our presenter. And I believe, is it Kayla who's going to present for us today? If you want to come off mute and begin your presentation.
I think I'm going to do it, and Kayla can hop in if she needs to. All right.
All right, I think perfect.
Awesome. Okay, so my name's Emily Johnson. I'm the director at Symmetry Care. I was formerly our RN and compliance officer and reported on all these metrics up until recently. Kayla's in that role now, but I will tell you about how we do our workflows and lessons learned through the IET metrics. So you can go to the next slide. Okay, so our strategy, and I'll go into more detail in just a little bit. So we have direct and meaningful communication with providers who diagnose the patients with these. As you may know, we live in Burns, so a rural area. So we have the blessing to be able to have frequent and pretty simple contact with all of our providers in the county. And then we also have done training with the providers and given the ED providers some tips and tricks about how to avoid like the dependency diagnosis so that clients don't hit the denominator when they shouldn't be hitting the denominator. So we've done trainings with providers about that. We've developed clear lines of communication for referrals for the clients receiving diagnosis. And then we have a point person on both ends to ensure the client receives the resources necessary. So Kayla is our point person on our end now. And oddly enough, there's another Kayla on the other end that she communicates with about these clients. And also EOCCO and GOBI help a lot with letting us all know when somebody has hit the denominator so that we can help them meet the metrics. Okay, next slide. So our workflow is a client receives a diagnosis. Kind of like Jen was saying, we also use point-click care and we get notified by GOBI every morning if somebody has hit the denominator. And Kayla looks at point-click care every morning and she sees those as well. So if it doesn't happen through the ED, say their primary care provider diagnose them with a dependency, SUD diagnosis, the provider will flag the Kayla on the other end, and Kayla will let us know and send a referral. So the provider on the other end will send a referral to us. Sometimes it's more urgent, and we have a 24-hour on-call SUD recovery phone. So, and all the providers in the county know that they can call that phone. So sometimes they'll just automatically call that phone, and one of our SUD providers will go out immediately and do like a warm handoff. If the warm handoff doesn't have to happen, we'll get the referral and we will get the person scheduled within 7 days. Usually it's sooner. If our scheduling is out further than 7 days, we have a walk-in clinic every Monday. If it needs to be more, if it's more urgent than that, we can usually get an SUD provider to do an assessment right away. And then our follow-up, so the primary care provider clinic usually reaches out to us to make sure that the client has shown up and that we were able to see them when we needed to see them. And then we communicate back to the primary care provider based on the client's wishes and their releases of information. So next slide. So lessons learned. Communication, clear communication pathways are essential. Kind of like Jen was saying, you have to know that line of communication so that things don't get dropped along the way. And we also establish really good rapport with our community partners, and, you know, teaching them that we're always willing to take every referral and we want to, and they can also reach out to us at a moment's notice and we can help do warm handoffs. Education, so educating the providers about the importance of the metric as well as the weight of the diagnosis they're using. I don't know if anybody has had these issues, but we were having issues with like locum ER providers diagnosing, you know, severe alcohol dependence. And then we were doing an assessment with the person and turns out, you know, they had one binge drinking episode and they don't usually drink, but they showed up to the ER because they were scared. And the diagnosis was completely inaccurate. So we did a lot of education with the providers about that. EOCCO also put out a good kind of one pager. It's even smaller. It's like a little pamphlet about what diagnoses to use and not use and what would be more appropriate. So we use that to help educate providers as well. And then patient outcomes. So careful care coordination has resulted in better patient outcomes with timely referrals and access to services. As you all probably know, the quicker we can get clients through the door and get the services going, the more likely they are to stay engaged in services. And I think that's a huge thing with our SUD recovery phone that has helped a lot, because we can go do those warm handoffs and get the ball rolling right away. So next slide. I think that might be it. I'm not sure.
That's your last slide. Sorry,
Okay.
Emily.
No, you're fine. Any questions?
Yeah, if anybody would like to either put a question in the chat or raise your hand, please do so. We've got one from Katie. Go ahead if you would like to.
Yeah, I was just curious how the provider education in your community was received when you first did outreach, saying we wanted to kind of talk about diagnoses and making sure that we are connecting with the folks that we really need to connect with.
That's a great question. So we sent an email out to like the hospital admin and just gave them the resource and said, you know, we are more than willing to come talk to providers about this if needed. They posted it in their ER, and so it was readily available for those providers. And along with the SUD recovery phone number for them to call. So it was more of a informal education. At the clinic, we were able to do more of a formal education with the providers who were willing to come. But again, we provided them with a little handout thing and the SUD resource phone number. And that I think was really helpful with them having a number to call when they're not sure what to do. And also I'm sorry, my son is here. I'm actually on vacation, but we giving them that number was super helpful. And then the Kayla on the other end, we were able to do a lot of education with her and explain that pamphlet to her. And she has great rapport with the providers in the clinic. And so she was able to really talk to those providers about it. And when she would see an SUD diagnosis come through, she would talk to them like, hey, are we sure this is what fits, or is it something else? So that's how we kind of approached it.
Perfect. Thank you. David, do you want to ask your question?
Yeah, I'm just wondering, I'm just trying to envision how this is going to work. You know, we have several substance abuse providers in our area. And so just wondering how, I don't know if you all encounter that, but just wondering how that would work when you might be delivering one part of the service, but somebody else is potentially delivering another part of the service.
So I know for EOCCO, and I think OHA can speak for this too, but it's a county-wide metric, and for EOCCO. So if the clinics get the encounter accomplished, it still counts towards the numerator for EOCCO. I'm assuming it's similar for OHA, but I'll let them weigh in on that.
Yeah, it's based on where they're getting the care. So we're looking for clients who are getting care at the CCBHC. I don't know if that answers your question.
It kind of does. The only problem, like I said, is, you know, because there's multiple substance abuse providers, we may be providing one aspect of care, but the other aspect of care is actually being managed somewhere else. And so that it makes it a little bit harder to manage that responsibility directly sometimes.
Yeah.
I have a question on that too, I guess. If they are not active in our system as a SUD client, would you just not count them in the denominator then?
Right. So we do get generally the overall process is we get client rosters from you all. So that's sort of the basis of our initial for all of these metrics, we start with the client roster. We do a little bit of QC on our end too with the client rosters, but we are starting with client rosters that you identify and then looking at any care that they got for these metrics in general. That's kind of the process. I don't know if that helps kind of answer that question. I think Jerry might be next.
Yeah, and just going off David's question, we're one of those providers in the county he's talking about. And for example, for SUD, you may have somebody who gets assessed who needs to go to residential, and that's not part of the CCBHC required levels of care, for example. So they may come to us for the residential, and then they could transition back for outpatient either to us again or to the CCBHC. I think what we're trying to get at here is how do you track that when the person is outside the CCBHC for a service that's not part of the requirements, but is necessary for their treatment, and then coming back in possibly either to a different provider that's not part of the CCBHC, or maybe at some point does come back in. That's, I think, simpler when they come back into the CCBHC.
Yeah, so in general, we are able to see, we're looking at all their, for your clients, we are able to see any sort of Medicaid services that they get. So it's, so we're looking at all Medicaid claims for them for.
So do they get excluded from the denominator while they're outside of the service, or do they automatically include it in the numerator because they are getting a higher level of care? I guess that's trying to understand how that affects the
Yeah, I
metrics.
would need, to be honest, I would need to go look at the specifications. I'm sure that's outlined in there, and I would need to double check to make sure I don't misremember and misspeak. If you don't mind, do you mind plopping that in the chat, and then I can make sure I'm speaking correctly after double checking my memory from the tech specs.
Okay. Thank you.
Unless Katie knows off the top of her head, but yeah, if you don't mind plopping it in there, we can follow up on that. Any other questions people would like to, for our speaker in particular? If not, we can go to the next slide. I think I'm going to present one more metric just briefly as an overview, and then we'll open up for any other lingering questions or suggestions for future topics. So do you want to do the next slide, Katie?
Yeah. I'm also happy to present this, but I'm not going to
sorry,
fight you for it.
I'm mixing up who's doing what. Sorry. No, I'm passing that to
No.
Katie.
Okay.
Thank you,
I'll take
Katie.
over.
No, it's all right.
Okay. So the next one that we're going to be discussing is preventative care and screening, unhealthy alcohol use screening, and brief counseling, which is also ASC. All right. And apologies ahead of time. I live next to a railway, and sometimes you can hear the train blow its horn. So sorry. Okay, so for this performance measure, the ASC measures calculate the percentage of clients age 18 years and older who were screened for unhealthy alcohol use and using a systematic screening method at least once within the last 12 months, and who received brief counseling if identified as an unhealthy alcohol user. So the numerator is the current and prior year. So a good example would be January 1, 2024 to December 31, 2025. And then when it comes to the denominator, this is a 12-month reporting period, so a full calendar year. An example being January 1, 2025 to December 31, 2025. And like I had mentioned at the beginning of this presentation, this particular measure is calculated by clinics. So just as a FYI. Oops, sorry. Whoop, whoop. Oh gosh, hang on. Okay. All right, so the screening methods that are available, this particular measure only needs one of the following systematic screening methods to assess unhealthy alcohol usage. So that would be the audit, as well as the audit C, which is just the abbreviated version of audit. And then there is this phrase here, how many times in the past year have you had 5 or 4 or more drinks in a day? This particular phrasing is directly from the tech specs. So you're welcome to use that as well. And then the highlighted audit and audit C, it goes directly to the link if you need to look at that. For this particular measure, it doesn't specify which staff should do the screening other than by inclusion of specific codes designating an eligible encounter. And just know that the CCBCH should follow any state or other requirements for licensure and training that would otherwise apply. Additionally, if another provider has already completed the screening within the allowed time frame, the CCBCH does not have to collect the information again. However, the CCBCH must ensure that individuals' responses are readily available for clinicians to review. And another note here is, so we at OHA understand concerns clinics and community have expressed in the gendered language and scoring of the audit and audit C. Unfortunately, this metric is federally required and copyrighted, and we are unable to change the requirements of this metric. All right, right, so for the ASC, there are two submeasures. Submeasure 1 is surrounding all clients who were screened for unhealthy alcohol use. The eligible population is new clients 18 years of age and older on the date of services during the measurement year who have at least who have at least 2 encounters at the CCBCH during the measurement year, or clients who have had at least 1 preventative visit. For the numerator, all clients in the denominator who were screened for unhealthy alcohol use using a systematic screening method at least once within the last 12 months. And for the denominator is all clients in the eligible population. There are some exclusion criteria, such as clients in hospice or clients with pre-existing or already documented alcohol use disorders. And also, as mentioned, all relevant numerator and denominator codes and different definitions and guidances on brief counseling and can be found within the text specs that are located at the end of this presentation in the resources area. For the second submeasure, this is including all clients who are identified as an unhealthy alcohol user and who receive brief counseling. The eligible population for the second submeasure is exactly the same as submeasure 1. The numerator is all clients in the denominator who have received brief counseling, and then for the denominator, all clients in the eligible population who are identified as an unhealthy alcohol user when screened for unhealthy alcohol use. All right. And that is it for all of the metrics that we were going to go over today. And now we have some Q&A and peer learning discussion. So yeah, so this includes different presentations and successful strategies for particular metrics. It's different overview of data use in the community needs assessment, using and interpreting the metrics dashboard once we get that online. But we also were curious to know if there are any other ideas or things that you'd like us to have, like to bring to this presentations to have as a greater discussion. We're always welcome to listen to those.
Yeah, and I think we could also, Katie, if it's okay with you, open it up generally right now. If people have questions they would like to bring to the group, they can either plop them in the chat or raise their hand. And I put this in the chat as well, but I wanted to confirm for everybody that I just went back and confirmed my memory in the text specs for Jerry's question, which is that those people who got a higher level of care than is provided by a CCBHC would be included as having met the metric rather than excluded from the metric. So I just wanted to mention that just in case people weren't monitoring the chat. But yes, in general, I think now is a good time for either questions or suggestions from anyone on the call, if anyone has any. And if people don't have any right now, our emails are always open for any suggestions or questions that you would like us to address in future meetings. Or if you have a top, oh, good, David.
Yeah, just to go back to the follow-up around the substance use diagnosis. I just take it that some codes, some billing codes show up on the mental health side and the substance abuse side. So I'm assuming that to be able to do this, we would have to have some kind of code that was only on the substance abuse side. I'm thinking of some of the therapy codes, the treatment planning codes, some of those things that I assume would not show up. And so then we'd have to narrow it down to one of the specific codes that are only on the SUD side. Is that correct?
Yes. So there is a giant list and in the text specs of all the codes that are in and out for kind of all of the metrics and how you define them. So it's really outlined in a lot of detail there if you want that level of detail. But yes, is the short answer. And we have that link in the resources section if anybody wants to get into that level of detail, especially for the ones that we're calculating. But yeah. Tracy.
Yes, I'm Tracy Nettleton. I'm from Tillamook Family Counseling Center. I'm the data systems manager there. So we are in the stage of just thinking about becoming a CCBH. And so I'm wondering if you can point me in some resource directions for us just getting started.
That's a good question. Well, first of all, we have some metric related resources in these slides. I don't know if anyone on the call has suggestions of, we have including in the slides, we have links to the OHA and like SAMHSA websites, and those both have a lot more resources that you might be interested in looking at. I don't know if Katie May has any suggestions on that. She might know more. Oh, perfect. Yes, exactly. She plopped in the chat. Thank you. And if anybody else on the call has any other suggestions of things that they have found helpful, that could also be really good. But there's a lot of information at that link that Katie put in the chat that is also linked in the slides, the sort of general resources on the Oregon website. Anybody else has any, they're welcome to put them in the chat or and if you, in general, if you have metric related questions or suggestions on topics that would be particularly useful for new or potential providers that you'd like to add to kind of the list we have here, we're always open to suggestions. Does anybody else have any questions or suggestions for topics or anything they'd like to ask the group or our presenters? Katie.
This is kind of not necessarily a collective discussion, but I would love to be able to have space to meet with folks that use the same documentation or EHR system that we do and kind of see what how they're utilizing it, if there's spaces they've learned that we haven't learned. And I know not all of us use the same EHR system, but it might be helpful if we could do that in some space, even if it was like this meeting and a breakout sessions where we got to chat with folks that use our same EHR and see what they've figured out.
That's a good idea. Yeah, let me talk to Katie about how we might implement that using breakout sessions or something like that. Yeah, that's a good idea. Thank you for that. And yeah, we will have to the people in the chat, we will have more presentations from providers on some of the other metrics coming up in the next, I think in the next two sessions, we have people scheduled, if I'm remembering correctly. So there will be more of those. And we really, really appreciate the presenters for putting together the slides and taking the time to do that. So I'm glad that was useful. Any other suggestions or thoughts, questions? Jennifer.
Hi, oops, I clicked my thing over. I just was thinking about the last question, and I know that Angela, who's like our all-star CCBHC person, I think she used to lead like a data session with people who used Credible EHR separately within the state. And then now I know Ocean Epic is building a lot within Compass Rose, and we have like a whole group of people that are working on it. So I'm just wondering if there are already separate subgroups of people connected already who are a CCBHC that use the same system. There might be things already happening.
That is a very good question and a good point. Yeah, if people know of things like that and would like to either put them in the chat or let me and Katie know about them, we're also happy to sort of disseminate resources that may, Katie, that may already exist.
Oh, I do not know of existing ones per se, but I've heard that some systems have their own spaces where people meet, and you can meet with people across the country who use that platform, some of which who may be CCBHC. So I raised my hand to say you might reach out to your platform people and see if they have spaces as well. And that might broaden the scope of who you get to meet with and learn from.
Thank you. That's a good idea. Anything else from anyone? I don't know if you want to close this out, Katie, or would you like me to?
I can. That's totally fine. These are all really great questions. So thank you so much for bringing them up and suggestions as well. These are fantastic. Okay, so these are just all of the resources that we have, like Gina was mentioning. So we have the OHA CCBH website, clinic metric facts, data reporting templates, metric screening tool requirements, communities assessment template and guidance. And then we also have some external resources, which is primarily SAMHSA's information. So you have the tech specs, the guidance, webinar series, quality measure facts, and then the National Council for Mental Wellbeing is also a phenomenal resource to look through. I know they hold some different sessions and whatnot. And then also, And then also when it comes to the medication list directory that I was talking about earlier, you're welcome to click on the here area, and it'll take you directly to it. And like I said earlier, just make sure to use the correct year. And then we have some provider resources. So again, the OHA website, we got data and reporting. If you have any questions, comments, suggestions, literally anything, if you just want to talk with us and have a good old chat, we're also very chatty people. So happy to do that. Just email myself or Gina. And then if you have any questions on any program requirements or cost reporting, the emails are right there that you can reach out to. And last but not least, thank you for everybody who has come today, everyone who has presented. This has been absolutely fantastic. So we're very, very thankful for everybody who's come today and has taken time out of their day. But yeah, if you need any this document in other languages, large print, Braille, or any format that you would like, just let us know and we'll get to you.
And I think just otherwise, we will be sharing the recording and the slides to the people on this calendar invite probably in a couple days.
Yep, exactly.
Thank you so much.
Yeah, thank you. Have a good rest of your day.
Thank you again to our presenters.
Christy, I think you can stop recording now.
Already did. So that'll take some time to percolate, and depending on when IT can upload it, maybe I'm hoping by the end of this week, certainly that'll be available with the slides.
Okay, awesome. Wonderful. Thank you so much for all your help.
Great job, everybody. Take care.
Have a
great day.
Bye.